California. So pleasure to talk to you again. I will go ahead and continue to answer those questions where I left off yesterday. Again, very important to kind of educate yourself about what is the hard objective evidence. As you will see, this is not my opinion. This is objective evidence that I'm going to read for you so that you can understand and you can read between the lines as to what is the thought process in regards to what my practice is about and why is it that I do in the manner that I do. So Mara, you can go ahead and ask any additional questions.
Okay, so first question is it really important to remove the capsules?
So this is truly what is the heart and gist of the explant surgery. Anyone can remove implants. That's relatively, I use the word straightforward and easy. This whole surgery is all about the capsule. And not only the capsule, but also about that inflamed tissue around the capsule. And so this is where, for example, let's go ahead and look at the hard evidence. Why do you want to do an en bloc, or why should we do a 100% total capsulectomy? Now, what's interesting is I go online and I see some patients that have brought forth some concerns that other patients have brought forth and say en bloc is overkill, or another plastic surgeon called me in, or another conference that I was at, and they say en bloc is not the gold standard. Well, I will beg to differ, because in my practice, for example, number one, we want to be able to remove the entire, so these are the reasons what I would say why I would justify and defend why the en bloc or 100% total capsulectomy is the key. First and foremost, within the last year and a half, they have had 3 patients that had CD30 positive within that capsular tissue. And there was a big red flag for what is the BIALCL, which is the breast implant associated anaplastic large cell lymphoma. Now, these 3 patients already had their total capsulectomy performed, or en bloc. They did not have to come back for round 2 for removal. Now, we do not know basically what's the long-term effects or the implications behind that, but they were nonetheless CD30 positive. They were referred to a medical oncologist for evaluation at a cancer center. And the bottom line here is that this is where we do not want to go back into the case, into the chest, and remove the residual capsule, because the standard of care, the surgery of choice, and this is mandatory, it is malpractice if you have someone with BIALCL to leave the capsule behind. So you might as well do it right, correct, first time, because you cannot tell by looking at it with the eye. You have to look at it under the CD30 stain if this is the BIALCL and not. And you do not want to be thinking about coming back because that in itself is going to be a very challenging, involved surgery. So you want to do it right, you want to do it completely and comprehensively. And so in these 3 patients, they got the best surgery to begin with and their best foot forward. The second thing is, if you look at the objective evidence from the pathology report, so my own patients' capsules were sent to pathology, and the pathology report came back, and I have some representative sample reports, and I'm going to read those out with the black markings for HIPAA compliance. This is over here, CD30 analysis does not highlight large atypical cells. This is where, as you will see, right breast implant capsule, that's the capsule on the implant that was sent to pathology. And I always mandate that the pathologist do the CD30 analysis and also look at the capsule itself. And so the doctor over here, specifically, doctor by the name of Paul Mazzara, who read this report, who is a pathologist, says, fibrous capsule with foreign body giant cell reaction to rare droplets consistent with extravasated silicone. So there's silicone within the capsule. So anyone who says leave the capsule behind, you're going to leave the burden behind. And you will see on the left capsule, it says fibrous capsule with mild chronic inflammation and droplets of material consistent with extravasated silicone. You do not want to leave that behind. And so this is another second proof that do it right, do it complete, do it comprehensively, because you cannot tell by looking at it with your naked eye, i.e. the surgeon, that this is good or not. You will see focal, this is on another patient's pathology report, right breast implant capsule, focal histiocytic infiltration. And this is the chronic inflammation, for example. On this patient, another pathology report, it says right breast implant capsule. There is benign soft tissue changes compatible with implant capsule, including fat necrosis, which is dead fat. So it's not only important to remove the implant, plus the capsule, plus that inflamed, angry, irritated, abnormal tissue around. So that's the dead fat. And then it says over here, comment, refractile foreign material identified which may represent breast implant particles. So they're telling you that that capsule has in it particles of silica, and these are basically the leaching effect. And these are my patient's pathology reports. So that in itself is the proof is in the pudding, or like the smoking gun, if you will, that why you should remove the entire capsule. And again, as another pathology report, just to kind of highlight the obvious, that shows that the capsule must be removed. Now, the third thing is, if you look at this breast implants, certain labeling recommendations to improve patient communication. So this is, remember, my third hard evidence. Food and Drug Administration issued September 29, 2020. Please see this. This is guidance for industry and Food and Drug Administration staff. It should also say patients, because remember, the patients are signing off on this. And it says over here, everything one needs to know about, the black box warning right here, the implications behind getting implants, the BIALCL screening recommendations, among others. And you will see over here on page 13, and I want each and every one of you to read this, because remember, these are not my words. It's not AI generated. It's generated by the FDA, because they are looking out for the patients and they want the patients to initialize. It says over here, systemic symptoms. I understand that some patients have received breast implants. Some patients who have received breast implants have reported a variety of systemic symptoms, including joint pain, fatigue, rash, memory loss, and brain fog that some patients have called breast implant illness. So they're telling you breast implant illness exists because here it is. Number two, they should actually step up and say, there is an entity called breast implant illness because it exists, because the patients are seeing. This is just like saying some patients have gotten up and said, well, I've got Hashimoto's, thyroiditis, autoimmune, and they're like saying, oh, some patients have reported some symptom called Hashimoto. No, just step up and say that breast implant illness exists and have an ICD-10 code for it, because you're acknowledging the fact it does exist. While the causes, to continue, quote, while the causes of these symptoms are unclear, some patients have reported relief of these symptoms with the removal of their implants and surrounding scar tissue capsule. However, not all patients may experience improvement in their symptoms. Researchers are working to better understand the possible link between breast implants and these symptoms. And so the bottom line here is that they're telling you remove the capsule, removal of the implants and surrounding scar tissue capsule. So they're telling you remove the capsule. And we've seen that. Number four, if you have seen many patients that I've operated on where they have had a ruptured implant, you want this all contained. So you don't want the silicone to spill into the chest, the slime, if you will, that non-cohesive implant to spill into the chest because it was ruptured. And you're not going to wash it out and put drains in and call it a day, because that is bad surgical technique. The right proper way is to do it en bloc, such that all of it is contained. None of this silicone spills into the chest. It is 100% along with the implant capsule and that inflamed tissue removed. So that you saw the case of the very nice patient from the 83-year-old patient. She had both an intra and an extra capsular rupture. Everything was contained. All bad inflamed tissue was removed, and that it was sent to pathology so that there's only good, healthy, viable tissue remaining behind. And that was the en bloc gold standard, such that none of the silicone spilled into the chest. Anyone will tell you, you have to contain the badness such that none of that silicone spills into the chest. And that is where you have the fourth proof. Why would you want to let that silicone spill into the chest or leave the capsule behind? Number five, we have a series of patients who had their surgery done by what was a surgeon who was not a believer in breast implant illness, did not want to think about removal of the capsule, and these patients did not improve. and they continue to have their many symptoms of breast implant illness that lingered on. And now these patients then sought out another surgeon who then removed residual capsules, and now these patients improved. That in itself is another in itself proof, because the patients are telling you remove the capsule. So do it right, do it once, do it definitive, do it comprehensively. We just released a series of questions to ask your surgeon in regards to, are there believers of breast implant illness? How many explants have you done? Do you take high definition pictures and videos? What is the length of the surgery? What is the length of the incision? How basically do you send the capsules off to pathology? Do you use drains or not? Do you basically believe in complete removal not only of the implant capsule plus all of that inflamed tissue? And there is a transparency into this whole process. There is a certain etiquette. So that, and I've said this many times, if I go back and look at my patients, I tell my patients I could not have done the surgery any better. 20 years from now, I cannot imagine anyone else being more complete, because we're already being complete and thorough. Are we being overkill? And this is where the consensus is, it's invasive. Yes, it is involved surgery. Any surgery is involved. Yes, is it long? Yes, it is long. It takes half an hour, 45 minutes to put in implants. It takes almost 4 hours plus minus, depending on the size of the implant and how it was placed, to be able to remove it correctly. And the whole surgery is based off doing it in a very thoughtful, sophisticated way, such that when we look back at it, we could not have done it any better. And there is complete transparency into doing the surgery. So this is by far what I would say is the heart and gist of what is explant surgery. And it is surgeon dependent. There's a mindset and a skill set the surgeon has to have in his mind or her mind, that the capsule must, and the entire implant and inflamed tissue must be removed as 100% total capsulectomy or an en bloc. And number two, the skill set. There are many surgeons who want to go in and remove the capsule in en bloc, and unfortunately, because of that sophistication and the meticulousness of the surgery, they're not able to do so. So you want to make sure that you have that content meant from your surgeon, that he or she is directly telling you that they will remove it. It's on that consent form. That's the medical legal bind you have with the surgeon. So you're not second guessing the process. Again, very thoughtful, systematic approach. And the best way that anyone can initiate this process is to join a Facebook page of that surgeon, so you learn more about the surgeon rather than taking the surgeon's words. We have surgeons doing surgeries in an hour and a half, 2.5 hours. And unfortunately, as you can see, in 2.5 hours with fat grafting and a lift and a supposed en bloc, that surgery cannot be done in that fast of a period, because it takes time and effort to be removing the whole capsule.
Next question, Dr. Khan. How do breast implants affect mammograms?
So this is a very good question. And again, I don't want to say or do anything other than I want to go ahead and read this off. Again, this is the breast implant certain labeling recommendations to improve patient communication. FDA issued September 29th, 2020. It says over here on page 14 at the top. I understand that all breast implants can interfere with mammography and breast exams. Remember, 1 out of 8 or 9 women in the US will get breast cancer. And remember, the mammogram is the standard of care. Millions of patients have had early detection of breast cancer as a direct result of getting a mammogram. And certainly the self-monthly breast exam is key, probably the most common reason how breast cancer is picked up. So it's telling you, quote, I understand that all breast implants can interfere with mammography and breast exams. That in itself alone should be a reason to not get an implant, if you ask me. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause that breast implant to rupture or leak. I should tell the mammography technician if the breast implants, if I have breast implants. And so the point here is implants directly, as stated here. And guess what? They want you to patient's initials at the bottom. And so the mammogram and the self-monthly breast exam certainly is altered, and this is where you do not want to change the chest breast area, especially if you're screening for breast cancer, if you have a family history, or even if you remember, majority of breast cancer is spontaneous, it's non-genetic. So you want to do the self-monthly breast exam, and you certainly want to do the mammograms as directed by your primary care doctor, so that you appropriately screen, and God forbid, if you have cancer, you want to catch it early on so you don't have to deal with chemo or radiation or any problems later on in life.
How long do breast implants last?
So on average, anecdotally, 7 to 10 years. In my practice, I've seen patients that got them, and within a few months that they were reactive to them. There are patients that have received them, and 20 years later, they said now they started to have problems, be it a rupture, a capsular contracture, or some other malposition effect amongst the other problems. So it varies. So this one nice patient had implants from 1983. As you can see clearly, she was way overdue. She had both the right and left rupture, intra and extracapsular. They are not lifetime devices. Let's go ahead and go back to the same black box warning that we have read multiple times. And it says here on page 9, quote unquote, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are they will develop complications, some of which will require more surgery, period. Now, this is where the time will come into effect for the patient depending on her complaints, concerns, symptoms. Sometimes the symptoms are so subtle and not apparent that the patients feel that it's the stressors in life, it's the perimenopausal time, it is the stress because of loss of job or the tariffs, God knows what else. But remember, deep down within, if someone has all these complaints, and they have been worked up, and the workup is negative, now you have more and more fingers pointing towards what is breast implant illness. And remember, breast implant illness, if you look at the live question and answer session yesterday, they do not occur all the time. And so you could have very valid reasons, just time alone, to be removing implants. Some patients have come to me and they said they had implants for 12 years and they felt it was time to remove them before the rupture would occur. You do not want to wait for a rupture and then remove if it's been the 10-12 year mark, because you do not want this to spill into the periphery. So as you will see, page 14 at the top, I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes, under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of the silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. The point here is, you do not want to wait for a rupture and then say, okay, now I'm going to react, and the next thing you know, the silicone might spread to extracapsular tissues, to the lymph nodes. This one patient I took care of 2.5 weeks ago, she had a ruptured implant, and literally it was basically in the periphery into the armpit area and on the upper part of the chest, and something that is what is a dreaded complication of the silicone spread into the periphery as a result of the extracapsular rupture of the implant. So another important point to note here is this, and this is kind of directly related to that question. Page 14, recommended follow-up. Quote, again, the reason I read this is I want to give you not my opinion. I want to give you my hard facts, right? This is what everyone should know. This should not come as a surprise to anyone. This should be like, oh, I remember my doctor telling me this, or I remember reading it and signing out on that. Look, patient's initials. Patient's initials. This is a document that you should have memorized before you got the implants, and you know the implications. So quote, even if I have no symptoms, I should have my first ultrasound or MRI at 5 to 6 years after my initial implant surgery, and then every 2 to 3 years after. If I have symptoms or uncertain ultrasound results for a breast implant rupture at any time, an MRI is recommended. So they're telling you the MRI is the study of choice, and per guidelines, I'll show you that the MRI at year 3 and then every 2 years they're onward. So, quote, I understand that I will need routine and regular follow-up with my physician as long as I have a breast implant for examination of my breast implant, um, as well as to discuss any updates regarding breast implant issues. And then, so they're telling you that it does occur. Now, if you look at the manufacturer's warnings, for example, this is the mentor advertisement right here. You will see the mentor advertisement. And then it says, quote, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. So they're telling you the longer you have them, the higher the chance you are going to have a rupture. I removed implants from someone who had them in 2021, and 4 years in 2025, when I removed the implants, the right one was indeed very much ruptured, to my total surprise. And I've removed implants from over 30 years ago, and both of them were intact. And this goes on to telling you, you never know. And who ideally, realistically gets these imaging studies? No. So there is a lifespan, approximately 7 to 10 years. Some people will say 10 to 15 years. Now, this is where, remember, you have to do your due diligence. Do you want to take care of a small fire versus a big fire? Do you want to take care of a ruptured intracapsular or intra and extracapsular? You want to take care of an implant that may be intact with silicone that's leaching into the periphery. And this is where you, as a patient, as the consumer, need to do your due diligence and homework and figure out what's going to be best for you.
What is the recovery time for implant removal?
So this is a very good question. If the implant is above the muscle, relatively smoother, nicer, better recovery. If it's below the muscle, it is going to be longer. Now, there are so many variables. You know, I have had patients, for example, that one patient, she wanted to go to physical therapy. You have to look at, if she were to go to physical therapy, she would run into complications. This is just like saying someone that got a tummy tuck at week 5.5. She's like, okay, let me go to the therapist because I've not exercised for the last 5.5, 6 weeks. And now I'm going to go kind of jump into the fire and do all these exercises because I'm losing muscle mass. Absolutely not. There is a certain, remember, it takes 35, 45 minutes just to put in the implants, almost 4 hours to removing them, especially when it is below the muscle. Now, the many variables come into play are, how good was your surgeon? Was he board certified? Was the implant above the muscle or below? Did you get chemo radiation if you were a cancer patient? Did you get alloderm cadaveric skin or not? If that was used in reconstruction, well over 85% of the time the alloderm is utilized. If you had 800 cc implant or 175 cc implant, if you had multiple surgeries done, for example, I have had patients, I just reviewed a chart on a patient who had 8 surgeries. So you can imagine her course is very different than the case that I did today, where the patient had only one salient implant placed in 2003. I have another patient that is heavy, BMI of 40. Her recovery is very different from the young 35-year-old patient who has a 18 BMI. A patient who's a smoker, so she just could not stop smoking. Her recovery is going to be different. Someone who is non-compliant and moving her arms 2-3 weeks out, simply because she does not have the personality to listen to instructions, her recovery is going to be very different than the other person who's been extremely careful, hands and arms tied. Now, someone who has a ruptured implant, someone who has capsular contracture, someone who has a biofilm, someone who basically has had good reconstruction, excellent results, but now because of the malposition effect, now the one side is different compared to the other. And I can come up with 10 more different scenarios. And the point I'm trying to make here is you cannot extrapolate one patient to the next. Another patient cannot go back and look at another patient's results and say, well, my other friend who had surgery the same day, you're advancing her, but you're kind of being hard on me. No, it's not about being hard. And remember, in my practice, I'm very much hands-on. You are dealing with me from day one, at the day of the surgery, post-op, and even afterwards when you're back home. And remember, 80% of my patients, plus minus, travel to see me. They're from out of town. And this is where I am able to individually follow them personally so that when you have your recovery, you have the best recovery possible. And just my international patient that I took care of, she's already like 70% done with her healing phase at just week 2, by the way, because of the extreme compliance she has, her small implants. and above the muscle and the many other factors, including very much so that she's being truly compliant. Another patient, for example, she's like, I have to help change the diaper at home. I have to be at home moving about and helping. Automatically, that patient is prolonging and delaying her recovery because she's moving her arms and being non-compliant. It's very analogous to someone, for example, two people who have a leg sprain, and it's exactly the same leg sprain. The first one is an 18-year-old boy who's playing basketball. 3 days later, 3 weeks, 6 weeks later, you're going to still see him limping. The other nice, smart, wise lady that most, if not all, my patients are, they're going to be rest, compression, ice, elevation, and being compliant with their instructions. And now at week 6, they're moving on to basically gentle, warm exercises to build up their pec muscle. Remember, it's directed by the patient for the patient because their one arm might be a little bit more involved than the other. If you go to the therapist, they're going to follow a certain protocol and they're going to tell you, this is your homework, this is what you have to do. And remember, when you go to the therapist is Monday, Wednesday, Friday. Over here, you're doing daily, morning, afternoon, or morning, evening, and as directed by me so that you get the best results. We do not want to push forward. And remember, you're going to be better than ever before. So when it comes to recovery, it's a very broad term, but within 6, 7, 8 days, I will say 80-90% of my patients are driving because they're off the pain meds, their reaction time is good, and they have the confidence in driving. Within 3 weeks or so, plus minus, most of my desk job patients are already at their desk job. The nice patient from overseas, she's back on her computer job 2 weeks into her explant because she's like, I can move my digits and I can work effectively. She's off the pain meds. Most of the patients, 70% of them, 80% of them don't take pain meds past 2-3 days. If you are a nurse and working in the ICU, lifting heavy patients, you may not be ready for 12 weeks, maybe a lot longer, depending on how you do with your recovery. So there are a lot of factors that come into play. And remember, the moment you got your muscle cut to get the implants below the muscle was compromised. The fact that you had the implants, that in itself was a compromise. The inflammation was a compromise. The fact that the muscle was cut is a compromise. The fact that you have these fibromyalgia type issues, neck, back, shoulder issues, the weight of the implants, that in itself is a compromise. And all the muscle over time atrophies, not only the pec major because it was cut, but all the muscles of the neck, back, shoulder, including the posture, gets negatively affected. For some patients, minimal. For some patients, significant to the point where they have to have chronic pain, neck injections, things like that. So if anything, improvement in the symptoms in itself leads to better recovery. And these patients are certainly very much appreciative. And this is why they proceed with the surgery in the manner that I do. And remember, this goes on to saying that most of my patients, if not all, have said they wish they had never gotten implants and they wish they had recovered or they had explanted sooner so that they could have had a better, faster recovery.
Does breast implant illness go away once breast implants are removed? How long does it take for symptoms to go away?
So this is a very good question. Now, the first and foremost thing is one of my other patients said her friend had her surgery done in Arizona. Another patient had her surgery done in California. And she said, well, my friend did not improve. My next question is, who was the surgeon? Do you have high definition pictures and videos of the chest wall of that patient showing that complete capsule removal was done? Because if the capsule was not removed, as you saw in the pathology reports from earlier, the patient's not going to improve. And now she's going to say, well, the explantation doesn't help. So the surgery has to be done right. That's the most important. I have a patient, she went and saw a surgeon right here in town. She got her explant surgery and she improved 70%, but she knew in her heart that there's some residual capsule remaining behind. And she knew that was the case because her gut told her, because she knew she had improved, but not completely, to the point where she sought out another surgeon out of town. And lo and behold, when that surgeon went in, concluded with definitive certainty, again, the high definition pictures and videos, that there was a residual capsule because the first surgeon did not do her job right correctly. That in itself tells you the patients are smarter than this process. They know what's going on. And the point here is you want to make sure that your surgery was done correctly and comprehensively, and you have the high definition pictures and videos of the chest wall showing complete removal of the capsule. And number two, once that is done, I tell my patients, sometimes some patients have a very dramatic recovery. Some patients have recovery within hours, right in the waiting area when they say that the eyesight is improving the next day, the energy is better, their posture is better, the overall improvement in the dryness of the eyes, for example. Now, there are some patients that said even 2 months out, they were like not improving. And then the third month, the patient just texted me and said, over the last 1 month, I've noticed there was a dramatic recovery. I did a Facebook Live with one of my patients from England, and she said that a year and a half, she thought she was still improving till the one day before. And so the bottom line is, remember, it takes you some time to get there. This is where you have to have the confidence that your surgeon got it all out completely, definitively, and you have the peace of mind that all of it was done and all of it was tested. And then you leave it up to time so that we will now see what is the after effect of the explantation and how it's going to benefit. Anecdotally, easily, I would say 90% of my patients have sought improvement in their recovery from what is strongly suggestive of what is breast implant illness, and you can certainly hear this on the many Facebook Lives. And the many Facebook Live interviews that I've done, and the many Facebook feedbacks that they have had. You will see on a very healthy platform such as mine and Facebook, there is an open exchange of dialogue between my patients and prospective patients, previous patients, so that you can learn from my patients how and what their experience was. And this is very important, transparent. Any patient who is on my Facebook page can direct message and have a full conversation about my patient's experiences, so that the next patient is only reaffirmed and at peace and has that excitement that, yes, this is what I signed up for. And this is very important. The surgeon should allow their previous patients to talk to one another so that there is a check and balance, not only on me, but each one of those other surgeons, so that they get the best experience possible, and which is what we try to achieve.
Are there risks of breast implants to unborn and breastfeeding children?
So this is a very, very good question. Now, I'm going to go ahead and read this. From the same FDA issued guideline. If you give me a second. All right, here we go. So this is again page 13 at the top, systemic symptoms. I did not write this. This is coming from the FDA, certain labeling recommendations to improve patient communication. And page 13, quote, I also understand some patients with breast implants have reported health problems in their children after birth or breastfeeding. While a causal link between breast implants and these reported health problems in children has not been demonstrated, more research is needed. I understand that breast implants and breast surgery may interfere with my ability to successfully breastfeed. Patient initials. Now this is where, if you look at the guidelines, you will be able to put the two and two together. You know, if you look at the hard facts, I'm going to go ahead and read this breast implant specific risks. I understand that a breast implant is not a lifetime device, and the longer I have my implants, the more likely I am to experience a complication, and the more likely I am to require a reoperation requiring the replacement or removal of my breast implant. As many as 20% of women who receive breast implants for augmentation have to have their breast implants removed within 8 to 10 years, but my implants may last for a shorter or longer time. I understand that my breast implants may rupture or leak at any time, and that the longer I have my implants, the more likely I am to experience a complication such as a rupture. I understand that gel bleed, small quantities of chemicals diffusing from implant shell of silicone gel filled implants may occur. I understand that if I have a saline filled implant, my breast may deflate in appearance if there is a rupture or leakage of the saline. I understand that if I have a silicone gel filled breast implant, I or the physician may not be able to tell on physical exam whether my implant has ruptured or is leaking silicone gel. Because of rupture or leakage of silicone gel filled breast implants is difficult to detect, I understand that Periodic imaging evaluation is recommended for screening of silicone gel-filled breast implants rupture. It is recommended that I have a periodic imaging of my silicone gel-filled breast implants to screen for implant rupture, regardless of whether my implants are for cosmetic augmentation or reconstruction. These recommendations do not replace other additional imaging that may be required depending on my medical history or circumstances. Screening mammography for cancers. So this is where, if you look at it, if I read all of that, it's only bad. There's nothing good. And this is the take-home point. Do no harm. And this is another term that I'm going to introduce, DNT, do not touch. I live by the DNT and do no harm. DNH, DNT. Do no harm, do not touch. Why would you want to get a Motiva implant? And there is like all this, wow, these are amazing, best, excellent, A+. No, it's not. You have to know the implications behind implants. A silicone implant above the muscle has implications, right? There are bad implications. They're only bad. Unfortunately, what surprises me is that this is like kind of the Wild West, if you will, that, here it is, the best thing, you deserve the best. But you need to know what you're signing up for. And that is a big problem because many patients do have no idea, completely clueless, because they're made to be sold like they're the safest devices on earth, and which they are not. And this is where you need to do your homework and you need to understand what you're signing up for. So if a problem does arise, you're not going to be like that nice lady who said, well, my doc told me they're meant to be in the body forever. That is wrong information. My doctor said, oh, you got a ruptured implant, don't worry about it. You're going to live happily ever after because it was picked up incidentally on an MRI or a CT scan of the abdomen pelvis. No, it is not healthy to live with a capsular contracture. It's not healthy to be living with a ruptured implant. And again, do your homework, do your due diligence, read up on it. And as you will see, it will be, quote unquote, a no-brainer as to what you need to do. And educate yourself because it does not take much to educate oneself. Now, if you please feel free to ask any questions you may have, be it on TikTok, YouTube, Facebook, Instagram, and we have questions from before. These are a series of questions that are very interesting. And if I do not know the answer, I will be the first person to say I do not know. And the other thing I want to mention, nothing that I have said today is other than what is objective evidence that I've read off.
I do have a question referring to the breastfeeding. How long do I have to wait to have surgery after having a baby?
So I will tell you, there are patients, for example, that I've taken care of. She had pain on the chest breast area. This mom is actively nursing and she plans on nursing. And lo and behold, she gets a MRI and it shows the right breast implant ruptured. We did a Facebook Live and I presented this as well before. She said, I don't care. I want the next available date. And lo and behold, we got her in soon. And she nursed in the morning at 9 o'clock. 1 o'clock was her surgery. And then later on in the afternoon, she pumped after her surgery and she continued to go on. Now, ideally, for your own comfort and for your convenience, if you want to stop, and then within 2 or 3 months, you will see the breast tissue is going to be not as stimulated, and you will then be in what is a convenient zone for you to go ahead and get the explant. Now, remember, in majority of the cases, if this is the muscle, the breast tissue is above, let's say, P1 level above the pectoralis major. P2 level is where most of the implants are below. I don't touch the breast tissue. That's a separate department, separate compartment. I have nothing to do with the breast tissue, the nipple areola. I'm always below. And so I don't touch the breast tissue, and I can certainly do the surgery. So for your comfort, ideally, you want to stop the nursing so that post-op, you don't have to worry about basically pumping or nursing, and you can have a very good uneventful course.
Are patients able to breastfeed while, during recovery?
Yes, absolutely. Okay. So my patients post-op, for example, and I did a Facebook Live almost a year ago with one of my patients. She was very nice and kind enough to come forth and discuss her journey about her post-op course where she actively nursed So if you go back, and Mar, you can go ahead and kind of resurface this. If you have time, and you should have time for yourself to look up all of these many Facebook Lives that I've done and listen to the many patients, you will get all your answers. I think I've taken care of every patient from, I've taken care of patients from almost every state of the US, and in the neighboring, between Mexico and also Canada and many other countries. And there were so many different situations that I've been in. Remember, this is the only surgery that I do. I only remove saline implants, silicone implants, and residual capsules. And that my practice is exclusively devoted to what is explantation. I welcome any plastic surgeon in a very nice professional way to come and debate me about implants, so that we can learn from one another as to what one needs to know, what are the long-term implications about implants, what is their opinion, and so that we can educate the patients, because ultimately we want to improve the quality of life of the many patients who are hurting, millions of which, and they do not know that the implants are not even in the equation.
Question from TikTok: how do I know if my implants are ruptured?
So the test of choice is an MRI without contrast if you have silicone implants. And this is no radiation, no contrast, and an MRI is the standard, the gold standard. Now remember, I took care of a patient almost 8 weeks ago from Virginia, a nice young lady, 31 years of age. She had an MRI done on the right and left. It said both of them were ruptured. And lo and behold, I went in and both of them were very much intact silicone implants. Saline implants, as you heard earlier, when they do rupture, they collapse completely. So it's like kind of, if you will, a flat tire, completely deflated. So that one side would be essentially flat chested, and the other side would be relatively large. It would be a dramatic difference between the two. And you will notice, depending obviously certainly on the size, and you will notice that this was an instant deflation. Saline implants, when they do deflate, they are like a water balloon. They collapse completely 99.9% of the time. It's not that they have a faulty valve leak, they leak a little bit and then they stop. No, they leak completely, and 99.9% of the time. And so this is where you have a difference variation. One patient ended up getting an MRI from her primary care doctor, and she had saline implants. And I told her, why did you do that? I can just tell by looking at you that both the saline are intact. And both of them were intact, because that's what the MRI said. Remember, saline implants, you do not have to have any imaging, because when if not all of them, basically when they do rupture, they rupture completely. Now you may have fluid around the implant, but there is an implication behind basically always assuming the worst. Whenever I go into any case, I always assume that both the implants are ruptured, and if they're saline implants, there's fluid around the implant, because I want to do it in the en bloc fashion, because that is the standard of care, or 100% total capsulectomy.
Is breast implant illness associated with cancer?
So breast implants have been associated with the BIALCL or the BIASCC, breast implant associated squamous cell cancer, breast implant associated ALCL, anaplastic large cell lymphoma. But breast implants have not been associated with breast cancers themselves. Now, one thing to note, as I read earlier, breast implants patients have, and now they are very uncomfortable because their last experience was painful, and they choose not to get a mammogram. Now the breast cancer is being picked up late. That's a problem. One person is afraid to get a mammogram, but she got one, but now the study was not the best because the implant got in the way. That is a problem. What did I read earlier? I understand that all breast implants can interfere with mammography and breast exams, the self-monthly breast exam, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implant to rupture or leak. Now, there are patients who said, I would love to get a mammogram, but I'm afraid it will rupture because my friend had a rupture. It has happened. Now, which is worse, to get a rupture, to get breast cancer, or to get the screening? The bottom line is get rid of the implant. That's what I say. Stay away from something that's going to get in the way between what is a good self-monthly breast exam, which is the most common way of picking up on breast cancer, or a good mammogram, because the implants are not worth the pain and misery of having breast cancer. Remember, again, 1 out of 8 or 9 women will get breast cancer. That's a very high number. That's the most common cancer in women, not the number one killer, but as far as incidence goes, the most common. As far as prevalence, the most common cancer in women diagnosed.
What about thermography or ultrasound? Follow-up
Good question. Thermography is not the standard of care. You go ahead and look at the false negative, false positive rate of thermography, and you will see that it has almost a 30 to 50% miss rate. Do they do thermography for lung cancer, pancreatic cancer, gallbladder cancer, anything? No. Thermography is an absolute certified waste of time. Do not do it. I've never even ordered one. If you go to the breast center, how many times do they get a thermogram? So thermogram equals waste of time. You get a screening mammogram, then they might want to get an ultrasound and ultrasound to kind of add to an area of interest. If they want to, then they may get a diagnostic mammogram, 3D computer aided design. Now they're using AI to kind of also pick up on what is breast cancer. And if they really want to, they'll get an MRI. And if they want to, they will get a biopsy. And this is where you have to go to the breast center, a reputable breast center, because this is all what they do from the morning, 8 o'clock till 6 p.m. They're fixated on breast pathology, breast masses, breast abnormalities, cysts, whatever it may be, so that they can work you up. And they know this better than anyone because they're fixated. Under the breast center, you have the radiologist, medical oncologist, surgical oncologist, plastic surgeon, you have pathologist, you have the whole tumor board that's kind of there, and they're all collectively thinking together rather than sending you to, well, go here at this location, a different address for imaging, go to a different center. They all converge in one, so kind of make it a one-stop evaluation at the breast center, because everything related to the breast kind of is right there for your convenience.
Will you remove Galaflex with the explant?
So what happens is that Galaflex, Galaflex, is supposed to get absorbed and basically forms a scaffold. Now, anything abnormal, irregular, looks abnormal, feels abnormal, a foreign body, Athabon suture, surgical clips, whatever it may be, even remotely suspicious, or if I'm sitting on the fence, should I remove or not, I remove it, because I don't want to give it a second chance. And remember, I've been being in the operating room since 1998. You have a good feel, sixth sense, if something is good, healthy or not. And if it's not, it has to go. Now remember, in the vast majority of the cases where the implant is below the muscle, there is a nice partition. Between the rib and the muscle, there is really not much. So anything bad is removed, and so there is no precious volume that's removed.
No more questions on TikTok. What about fat grafting? Will you do fat grafting?
So fat grafting to the breast, I say it is malpractice. Very strong word, but very appropriately used by me. I was once sitting at a major hospital system of the world. Chief of plastics was sitting to my left, and I jokingly but knowingly asked him, what do you think about fat grafting? Because there was a report that was presented. And he said, well, it's excellent, it works. And I said, how about some of the fat that may die and form clumps of dead fat, and now you're feeling a mass, or it's showing up as a calcification or an abnormality on an ultrasound or a mammogram? And he said, well, at least they look good. And the point here is not at the expense of potentially delaying, missing, or some patients that have presented to me from a major plastic surgeon's office where the implant was in the proximity of this mass, and they were thinking, is it fat necrosis from the fat grafting, or is this breast cancer, or is this just a granuloma? And they wanted to do a biopsy, but they were afraid to do a biopsy because they were afraid they were going to puncture and hurt the implant. So they said, get an explant. And the patient said, I want to get an explant because I'm anxious about this mass and it could be breast cancer. The bottom line here is, of the 100% of the fat that's injected, 40, 50, 60% of it does not take, maybe more. In some reports, you will see up to 80%. Now, some of it gets liquefied and the body absorbs it. Some of it takes excellent, gets the volume. Now remember, at any given time, 150 is injected because that might be a little bit too much depending on the amount, 150, 200. So it's not much. So some of it might take on one side, the other one might not take, and now you may have an indentation, a contour defect. Problems occur, patients have acute and chronic pain, small fat droplets, nodularities, irregularities that get picked up on a self-monthly breast exam or a mammogram or ultrasound. And now there's concern, anxiety about potential breast cancer being overlooked, missed. And sometimes the easiest thing to say is, oh, we'll come back in 6 months, we'll get another repeat study and say if it's growing in size, then we know there's a problem. You don't want to wait 6 months and say, oh, there's a problem. And now a good part of the fat is going to inevitably die. And now you need a second round or a third round. And I will tell you where you have something that is going to obscure or complicate, where fat grafting is done and it is fanned out such that it takes, because you want to spread the fat out so the blood supply will supply the blood to this fat that is being transferred, transplanted, and grafted. And this, remember, will lead to problems. And there are some reports, depending on the amount of fat, 3, 5, 7% of the time, the imaging is also affected negatively. Depending again on the amount of fat that is injected. You can get oil cysts, you can get acute and chronic pain, fat nodularities, irregularities. You have problems at the donor site and also the recipient site as well. You have, and again, you want to do your due diligence. In my practice, in my books, fat grafting, a big no-no, especially to a ruptured area where you have a lot of inflammation, and now you're going to do fat grafting and that fat might die. Infection can occur. Skin, irritation, redness, erythema, pain has been reported, like I mentioned earlier, just dull pain. So fat grafting to the breast, horrible idea. Fat grafting to the face, excellent idea. A+ idea, where you have small amounts of fat as a permanent filler, it works beautifully. But fat grafting to the breast, in my eyes, in my practice, what I would call clearly what is malpractice. So having said this, we will go ahead and please feel free to ask any questions. I'm here to answer any questions objectively from my experience. Do your research, do your due diligence. I want to go ahead and end with this. There are many patients that want to get like a mastopexy. I want you to go to YouTube and type in mastopexy or breast lift, lollipop anchor, cut around the nipple up and down. And I want you to see how invasive is that operation, what exactly that means, what it entails, so that you can understand the implications behind what is a lift operation. As you will see, 80% of my patients do not need that unnecessary lift, which means that that fatty tissue, i.e. the skin, is removed, that has been working as a skin access, and where I do the pseudo lift, the Kai pseudo lift, where the implant, once removed, now the gravitational pull of the implant pulling the breast tissue down is no more. Now the breast tissue recoils. The skin and the breast tissue, the younger the patient is going to recoil. Now that the implant is gone, there is fluffing effect of the breast tissue. Now there is no atrophy of the breast tissue. Anytime you have an implant in the proximity of the breast tissue atrophies, decreases, diminishes. With the implant gone, the breast tissue gets a chance to fluff out. Number 5, you will see that when the patients do work out, that 5, 10, 15% muscle mass they add to their chest. Ultimately, a year and a half later, patients are extremely happy that they did not need that unnecessary lift. Remember, I love to operate. I would love to do a lift on everyone, but no unnecessary surgery, especially in a time where some patients have gotten the unnecessary lift or even a necessary lift and now they have skin necrosis or wound breakdown because too much surgery was done on a day where the whole focus should have been on the explant, especially when it's ruptured or radiated or any other problems that are present. No taking risks and no unnecessary surgery, especially when that surgery may not be even required, for example, a lift operation. So 80% of my patients do not need that unnecessary lift. And again, do your homework, talk to the patients. Another patient asked me, well, I'm going to travel all the way from Seattle. And I said to her, well, you're going to get compression socks. Everyone gets heparin sub-Q. You're going to be up and about on the day of the surgery. The next day walking, you're going to have the twilight deep sedation, and the risk of you getting a clot essentially non-existent. And it is relatively a very, very safe surgery. And this is well, all the precautionary measures are undertaken. I recommend everyone to watch that Facebook Live I did with my anesthesiologist, Dr. Alamar, so you can learn more about our anesthesia perspective and how I feel strongly that all the other surgeons should incorporate so that we allow for our patients to have the best recovery from anesthesia as well. Something that is done in a very thoughtful, systematic approach by the anesthesia team member. So there you have it. Till next time. This is Dr. Khan, Executive Plastic Surgery. Please feel free to ask any questions for the next time we have this session.